excess bleeding and possibly uterine inversion. So I think this case was very interesting that it was done similar to the way that abdominal myomectomy is done, while other options include hysteroscopy, ligating loop, kiwi vacuum, which I feel like would increase the risk of inversion, and morcellation if needed. Thank you.
Thank you, Ray. Do you see anything? First of all, I don't think charity care is an issue in an emergency situation. I think if you have an emergency and you admit a patient as an emergency, I think you can do whatever procedure is necessary without regard to charity care. I think charity care is more important for sending someone home and scheduling them for a case. And I think on many of these patients' admissions, she would have qualified for emergency management and not outpatient scheduling. But with that said, Ray, do you think there's anything we could have done differently or better in this case?
So I think that is the biggest thing that we could have done differently, is for her to have been admitted earlier for surgical planning, because with the scheduling difficulty, because the GYN clinic gets booked up, the patient had about a month between when she first presented to when she could actually go to GYN clinic. So despite her being stable on her presentation with the prolapsing fibroid and dilated cervix, it would have been appropriate for her to be admitted for surgical planning immediately.
Are there any other questions? Dr. Misra?
Good morning. Thank you, Ray. Do you think, can you comment, or should I say, could you comment on the treatment with birth control pills, OC pills, for a prolapsing fibroid? Do you think that was indicated in this case, and would it have worked?
So it did not really work because the fibroid, first of all, was very large and it was prolapsing. So that was really the cause of the bleeding. So I don't think the OCP really worked, and that's why she presented after the OCP was initiated with heavy bleeding for a week, which resulted in her admission leading to the surgery. I did read that there are some pre-op things that can be done to reduce bleeding during surgery. So for example, we could consider uterine artery embolization if there's concern for heavy bleeding during the procedure. GnRH agonist is also an option to decrease the size of the fibroid or bleeding. However, that would take longer. So for a patient like this who already had a prolapsing fibroid with dilated cervix, that would not have really worked.
With only 60 seconds left, I see that Dr. Phillips has a question.
I just have a comment. I think despite the fact that she has charity care, I don't believe that makes things free to her, if I'm not mistaken. And I just wanted to make a comment that you got MRIs and ultrasounds and repeat ultrasounds, and you just increased the cost to this patient, even if she wasn't paying the full cost. And I wonder in retrospect if they really added a lot to this person's management.
When you could see the pathology right in front of your eyes.
Yeah, so she actually didn't end up getting the MRI because she represented, and we decided to just go to the OR. So that was good that she didn't actually have to wait for the MRI or pay for it.
All right. Well, thank you for that. Ray, excellent job presenting two very interesting cases. So thank you. So in just a minute, we're going to get ready for grand rounds, and I'm going to ask Dr. Leiser to introduce our grand round speaker. But in the meantime, just a comment or two about attendance. So we will be taking attendance this morning by looking at the names listed in the participants list of the WebEx. If your name is listed clearly, you will get full credit for attendance. If you have two people sitting at the same computer, or if you are call-in, then by all means, you can email your attendance to me or Michelle or to Beth. And with that, Dr. Liza, are you ready to introduce our speaker?
Yes, I am. So good morning, everybody. Welcome to Grand Rounds on this beautiful day. It's my honor and pleasure to introduce Dr. Mark Stein, who's going to be talking to us about medical ethics this morning. And I know Dr. Stein, not just from his years here in the operating room at RWJ, but also from the Hospital Ethics Committee on which we both sit. And he's kindly agreed to present a talk that I hope will be an initial foray and our first step into what will be a medical ethics education program for our residents. And that will involve ongoing lecture series and other activities. This is an initiative I'm really excited about, and I can't think of a better person to kick off the program. So Dr. Stein is a graduate of UMDMJ New Jersey Medical School, class of 1985. He began residency actually in OBGYN at University Hospital of Newark, and then changed specialties to anesthesiology, which he completed at Columbia Presbyterian in New York City. He began working here at RWJ as an assistant professor in 1989, working primarily as sometimes as an anesthesiologist on labor and delivery, and then retired as a professor emeritus many years later on April 1st, 2023, but he's still actively engaged in clinical work. And in terms of the ethics, you know, his knowledge is just vast, the different discussions I've had with him, and I see his comments and his participation in the ethics committee meetings. He is a member of multiple committees and societies, too numerous to mention. And in terms of the ethics committee in the hospital, he's been a member since 2018. So I'm really excited to hear what he has to say today. And without further ado, Dr. Stein.
Thank you very much. Thank you very much. It's good to be here and see old friends and you. We'll get started.
Hit it one more time. It'll work.
But I have no conflicts of interest to declare. This is an outline of what I've got contained in this morning's lecture. In the interest of time, there's no way we can cover all this. I'll try to stick with the most essential information that I want to transmit today. There are 4 principles of medical ethics. It's sometimes called the 4 ethical appeals. Number 1 is the patient's rights. Number 2 is our virtues as healthcare professionals. Number 3 is applying justice. And number 4 is providing beneficence and non-malfeasance. Let's go a little bit into each of those 4. The patient's rights. The most important right is the patient's right to autonomy, which is the right to decide what will be done to them. Number 2 are the non-decisional rights, which a patient can expect without having to ask for, that they will be protected from harm, you will respect their privacy, their confidentiality, you will be honest with them, and you will respect them. Our virtues as healthcare professionals are compassion, courage, self-sacrifice on behalf of patients, integrity, honesty, and respect. Those are things which we all should do at all times. Applying justice means treating patients fairly, equitably, appropriately, treat all patients honestly, do the right thing for the right reasons, and make sure that you're doing what's legal. Beneficence and non-malfeasance, that's the balance of benefit versus risk, good versus harm. You want to do what's beneficial for the patient, and you want to minimize or not cause harm to the patient. To do an ethics workup or to tackle an ethics problem, you get the basic facts, and then you come up with a course of action. Make sure that that course of action fits the 4 ethical appeals, and chances are you won't go wrong. Make sure you have a management plan and state clear reasons for your course of action, and at all times keep those 4 ethical principles in mind. Capacity is a term you're going to hear a lot this morning and all the time as far as the patient's ability to make important decisions. There are 4 aspects of capacity. Does the patient appreciate the seriousness of the situation and its possible consequences? Does the patient understand the relevant information that you're presenting to them? Does the patient show ability to apply reasoning to their treatment choices? And number 4, can they communicate their choice of treatment to you? Capacity is a clinical judgment by the attending physician about a particular healthcare decision. Now, capacity can improve or worsen depending on the patient's mental status when you interact with them. The level of capacity required for different decisions varies. For a very important decision, you need good capacity. The patient really has to understand a difficult proposal by you regarding an intervention. For something very simple like finger stick glucose, where there's minimal risk and there's benefit in the test result, you don't need a whole lot of capacity. Also, you don't need a psychiatrist to determine capacity unless the patient has a known diagnosed mental illness such as schizophrenia or manic depressive condition, and they've lost touch with reality in a particular phase of those conditions, or if the patient has a developmental disability. Otherwise, any physician can determine capacity. Here's a good table from an article in the New England Journal of Medicine about determining capacity. These are the four points that I had made about communicating, understanding the relevant information, appreciating the situation, applying reason to the patient's process of deciding, and how they communicate it to you. Here's some quotes from the state law about determining capacity. It's the attending physician's responsibility, and another attending should then confirm it. And you don't need a psychiatrist unless, as I mentioned a moment ago. Again, this is the details of the law, more details of the law. And once you determine whether a patient has capacity or not, you are obligated to inform the patient and their surrogate decision maker, their so-called healthcare representative, which is usually a family member. They have the right to appeal your decision. For instance, you think a patient has capacity, you get them to sign consent, and then the family's upset that, grandma has no idea what's going on. She's very polite and she agreed to sign your consent, but she really doesn't fully understand things, and they feel that you're treating them unfairly. And there are different laws in different states about how to go about determining capacity, who can, who can't, and so on. Here's a bunch of links to sources for different states, especially for the tri-state area. Okay, remember, when you meet a patient for the first time, maybe it seems like they have capacity, but you're going to do some kind of surgical or procedural intervention, and who knows what will happen post-op. The patient may need to remain intubated, sedated, they have a complication in the recovery room, they have to go back to the OR. It's good to touch base with the family, have the patient pre-op designate who their surrogate decision maker should be, usually a close family member. We'll talk more about that in a moment. You want to start that communication process pre-op. As you may know, there are two types of general categories. Legal capacity is decided by a judge. It's not always just for medical decisions, but for business decisions, financial decisions, and so on. And that's decided by a judge. Clinical capacity is decided by a physician, and it's pretty much restricted to making medical decisions. As I just said, if a judge decides that a patient does not have capacity, they may appoint a guardian. The guardian may be a family member, or if there's no family member available or willing to act as a guardian, then the judge may appoint a professional guardian, which is a whole different category, and that guardian expects to get paid by the family for their services, and we'll talk more about that in a moment. Also, when a judge appoints a guardian, they take it very seriously because you are removing a patient's rights, and the legal world takes that very seriously. A good thing for every patient to have is an advance directive. Only less than a third of all patients have one. An advance directive is a good way to state your feelings about different interventions, especially in life-threatening situations. And it's good for patients to have it, and along with the advance directive, going hand in hand is the medical power of attorney. In New Jersey, the medical power of attorney form is attached to the advance directive form. And this way, the patient has the ability to name who they want making their decisions if they become incapacitated. And there are several types of advance directives. The living will is the most common one. Most of it is in the form of a yes or no checklist. Do you want to be intubated? Do you want to have CPR? Basic things like that. There is room for the patient to fill in their own thoughts and concerns about different types of interventions. The living will can be very limiting in that it's mostly aimed at life-threatening conditions, or if you are expected to only live a short period of time. And a lot of it is very cut and dried, black or white decision-making. Do you want this or do you want that? Yes or no questions. The living will has its limitations, which is why the medical power of attorney is so important, because as you know, in critical care conditions, many decisions that have to be made are gray areas. It's not clear cut as far as risk and benefit. And the living will may not cover all those possibilities. So that's where a medical power of attorney comes in handy, so that the doctors involved can talk to the surrogate decision maker, the power of attorney, as far as making difficult choices and decisions that the patient did not cover in their living will. There's the physician's orders for life-sustaining treatment. It's a relatively short form, a few yes or no questions for the patient to decide, and it's signed by the physicians, by the doctor or an advanced practice nurse. It looks like a doctor's order sheet, and this is a good thing for patients to have with them, especially if they have a chronic illness and they may easily end up having to call 911 or finding themselves hospitalized. And this way they could show that, or their loved ones can show that to the doctors involved. Also, if a patient is living at home and they are DNR, it's good to have an out-of-hospital DNR order, so that if you collapse at home and you dial 911, the paramedics arrive, they will know that the patient is DNR. There's a psychiatric advance directive. If you have a psychiatric illness where you have episodes where you lose touch with reality, you as a patient can spell out how you want to be treated or not treated during those episodes. There's also something called the 5 wishes, which is an advance directive with similar aspects as I just mentioned on the other types of advance directives. But the patient has more room on the 5 wishes to talk about how they want to be treated in their final days. They can make statements saying goodbye to their family and their loved ones, how they want their funeral to be arranged, how they want to be remembered, and so on. So the 5 wishes is a much broader document. Here are some links to advance directive and medical power of attorney forms in the surrounding states. The attending physician is obligated to ask a patient if they have an advance directive, and to ask if they have a patient healthcare representative selected, and if not, if they could name one, to help with a lot of problems that may arise post-op. So it's good to, it's required in New Jersey that the attending physician ask that. Federal law requires hospitals to ask that. If you've ever been admitted here or even showed up for a same-day procedure, either the admitting nurse or someone from the admitting office will ask you if you have an advance directive. If an advance directive contains something which you as a physician feel is inappropriate, doesn't make sense, doesn't cover the current ongoing emergency or crisis that the patient was admitted for, you can either refuse to go along with it, transfer care to another physician, or the best advice would be to speak to the healthcare representatives, the surrogate decision maker that the patient has designated, or if they haven't designated it, whoever is willing to take that role, and to try to clarify what decisions should be made. And we'll talk more about that in a moment. Okay. If you don't know if the patient has an advance directive, they're brought to the emergency room, there's a crisis going on, don't wait to look around for the advance directive. Just go ahead and do whatever needs to be done and worry about finding the advance directive later. Now, most states have a hierarchy as far as who can be a surrogate decision maker if the patient did not designate one while they had capacity. In New Jersey, it's kept very simple. Either if there's a legal appointed guardian, that would be best. If not, a family member. They don't specify a hierarchy of which family member. And the other thing is others acting on the patient's behalf, which is vague, but perhaps intentionally so. Many states in their laws recognize the fact that family structures more and more contain people who are not blood relatives or relatives by marriage or other legal means, but rather a good friend who lives with the patient and is considered like part of the family. And so as a result, that third category is rather vague. And these are the details of the New Jersey state law. There are two important principles that a surrogate decision maker needs to work with. When making a decision about what needs to be done with a patient. Number one is substitute judgment. A surrogate decision maker needs to decide and think about what would the patient have wanted, what would the patient have decided, which is why it's always best for the surrogate decision maker to be a close relative or a very close friend who knows the patient very, very well. The second principle is what's in the best interests of the patient. It's not the easiest thing to try to decide, especially in a crisis, but those are the two factors that a surrogate decision maker needs to use: substituted judgment and what is in the best interests of the patient. These are some facts about other states and how they go about with these laws. And in fact, in most states, there's a hierarchy of who can be a surrogate decision maker if the patient never designated one in their advance directive. The patient's spouse gets priority, an adult child, a parent, or an adult sibling. Most states have those four as their hierarchy. And here's New York and Pennsylvania, as you can see. And as I mentioned earlier, more and more states are recognizing family members or non-relatives as healthcare decision makers, as I mentioned earlier. And here's some more information about that, about other states. Here at RWJ, from my own experiences with things that came to the attention of the ethics committee, we go by, of course, what the law is in New Jersey, which is a legally appointed guardian, if any, a family member, or someone acting on the patient's behalf. For some reason, there are 3 states in the United States which require a separate hierarchy if a incapacitated patient is wanted for medical research, and the family has to give consent for that. And New Jersey is one of those 3 states. And so as sort of a hybrid, we use those 3 principles of that I mentioned earlier that are state law and the hierarchy for medical research, even though it's not for medical research. So it's the legal guardian, spouse, adult child, parent if still alive, and a patient's sibling. And it should be noted that sometimes you can't get family members to agree on what should be done with their elderly incapacitated family member. And you should try to have them decide on one person to be the decision maker, and that person should get the consensus from the rest of the family. If you have a situation where the family just can't get along and can't make decisions, then a guardian may have to be appointed by the court. And there's a lot of complications with that, which I'll get into in a couple of minutes. There's such a thing as the unbefriended patient, which is recognized in the legal world. That patient who does not have capacity, they don't have an advance directive, there's no power of attorney, there's no guardian, there's no family, there are no friends. This patient is literally all alone in the world. And one of the many problems with this is the patient may be overtreated or undertreated as a result of having this status. You may feel that since you don't have consent from anyone, you're going to be hesitant to treat the patient because you don't have consent for anything. So you're going to wait till the patient's condition worsens and then it's an emergency and then you don't need consent. But that's a terrible way of taking care of people. There's also the over treatment, which is you don't want to be accused of neglecting a patient just because you don't have consent. So you're going to do everything that you feel needs to be done for the patient. You certainly don't want the Department of Health to be making a surprise inspection at the hospital and realize that this patient's been laying around and nobody's been taking care of them because there's no one to give consent. So a patient may very well end up being overtreated when the patient themselves, if they had capacity, wouldn't have wanted it. And as I mentioned, the two most important things are substituted judgment and what is in the best interest of the patient. And that's what any decision maker needs to keep in mind.
Yeah, because they're trying to get the guy out of the way.
Oh, man.
They just got him off the road.
Oh, this last.
Got it.
Okay, here's what the laws have to say about it. Here at RWJ, if you have such a problem with a so-called unbefriended patient, you want to get the social workers and case managers involved. They will be very helpful looking at old medical records, trying to find the name of a family member if at all possible. They'll even call whatever ambulance service had picked the patient up, find out where that patient was living, could even ask the police to go to that house and see if there's any family members. They'll try to look at what might be in the patient's wallet or personal items that they came to the hospital with. And if all else fails, they will ask the corporate security of RWJ Barnabas to do what a so-called skip trace. A skip trace is something that law enforcement and attorneys have access to. It allows them access to a vast government database involving the IRS, police records, state records of various kinds, to try to find where this patient came from, what other living relatives might they possibly have, what could they possibly find out about this patient. If they can't even find anything with a skip trace, the social workers and case management will contact the legal department and risk management to go to court and obtain a guardianship. As I mentioned, a guardian if a professional guardian has to be designated by a court, that guardian is entitled to compensation taken from the patient's assets or from public funds. It can be a very profitable business for a guardian. A guardian can have multiple guardianships going at the same time. There's a lot of abuse potential. Just click on any of these links to read about some horror stories. Once a professional guardian is appointed, it is very difficult to have it undone. I'm sure most of you are familiar with the Britney Spears case and how difficult it was for her to get rid of the the guardian that was appointed to her. Another good example is the legendary pop artist Peter Max. Those of us of a certain age remember him. He amassed a fortune. He developed dementia. His family could not agree on anything about any decisions involving him. A guardian was appointed by the court who was charging the family $550 an hour, sometimes around the clock. A famous piece of artwork by Peter Max, which used to hang outside of the pre-op area here. A movie about a professional guardian who cheats and swindles her clients, and a good article in the New Yorker on the topic. End-of-life discussions. Why are they so difficult? A lot of families, especially if there are no medical people in the family, they have a very distorted view of the realities of medical care and what we can and cannot do and what we're capable of or not. The success rate of resuscitation is vastly over-exaggerated. The public's trust in what doctors say has eroded over the years. Catastrophic medical problems are very complicated. Patients can have good days, bad days. It's very hard for a non-medical person, especially a family member, in such a time of distress, to wrap their heads around what's going on with the patient. Decisions are that need to be made about the patient. They're often gray areas. There are no clear-cut decisions. It's very difficult for a family to deal with. Here's the original article about CPR. They claimed a success rate of 70%. They said that anybody, anywhere can save a patient's life if they've had a cardiac arrest. All you need are your two hands. The media made a huge deal out of that. It turned into a whole cottage industry for certain people. What they didn't tell you is that they only had 20 patients in their study. They were all patients who had a cardiac arrest upon induction of anesthesia. And these were patients in the late 1950s. And I can tell you that most patients who have a serious problem during induction of anesthesia, it can usually be corrected. So it's terribly unfair to claim that there's a 70% success rate with CPR. End-of-life decisions, as I said, it's an emotionally charged time for the family, terribly difficult. They have to make sometimes impossible decisions. How do you deal with that? Arrange a group meeting, bring in all the healthcare providers involved, make sure everybody's in agreement on what we're going to talk to the family about. A few basics, explore essential issues with the family and what hopes they have. Discuss diagnosis, prognosis, what's the family's understanding. Use what's called your ears, your empathy, attention, and respect that you show to the family. Recommendations for care. Be careful with speaking to non-medical people and using medical jargon. One study that was actually done here by Dr. Koda, the chairman of the ethics committee, he's a critical care doc here. He used the phrase, allow a natural death instead of do not resuscitate when talking to a patient about end-of-life care. And they found that families were generally more satisfied with the patient's care as a result. The family is struggling with this. They are overwhelmed. Their coping skills may not be what you want them to be. Learn about the patient and their family, explore what the family is thinking, seek understanding of the family's perspective. One meeting with the family may not be enough. Always show empathy, attention, and respect every time you interact with the family. Remember, I learned this as a medical student from the chairman of medicine at University Hospital in Newark. A patient and their family's cooperation and compliance with your recommendations is directly related to their confidence in you as a kind, decent person and professional who truly seems to care about them. Please keep this statement in mind. Some more tips for speaking with families in a difficult situation. Elucidation, you want to provide good quality information, clarifying answers. Summarization, as you go from topic to topic, speaking to the family, summarize before you shift over to the next topic. Validation, make the family feel recognized, heard, and appreciated, sort of like that acronym of EARS. Shared decision-making. You've heard that phrase a lot. What's my take on it? I would say that if you've ever been to a therapist, a psychologist or psychiatrist, and you talk to them about a problem you're having, oh, I can't get along with people at work. I'm having a hard time at work because nobody likes me. That therapist is not just going to tell you, okay, here's what you got to do. No, they're going to ask you for details about, describe to me an interaction that leads to your feeling that way. What do they say to you? What do you say to them? What could have been said differently? What could have been done differently? The therapist will try to bring you to come around and have the answer to your own question, to your own problem. That to me is shared decision-making. You want to bring the family around to coming to their own conclusions when it comes to making difficult decisions. You provide the guidance and lead them along the way, but they will make the decisions by themselves with your guidance. That to me is shared decision-making. Again, here's a good article in which they go through those 4 points, elucidation, summarization, shifting, and validation. During CPR and ACLS, you want a member of the team to go out and talk to the family and keep them apprised of what's going on. Avoid the trap of being asked, what if she was your mother, what would you do? Go back to shared decision-making. You don't want the family to then later blame you for having made a decision which maybe you were right, but they will have second thoughts and doubts throughout the rest of their lives about whether they made the right decision because they had you make the decision for them. So don't fall into that trap. Some things to ask the family if such a question is proposed to you to try to get them to come to their own decisions. Remember, end of life and do not resuscitate discussions should be the culmination of a dialogue to understand the patient's wishes, values, and overall goals. And it all falls back to those four basic principles of medical ethics. Here's an original article. Well, it's an editorial 40 years after DNR was first formally proposed. The gist of this is that we used to ask patients for informed consent to get their permission to do something to them. Now we ask for permission not to do something to a patient, which is what DNR is. And cardiac arrest is not something that just pops out of nowhere. It's often the final step in the trajectory of predictable fatal illness. Communication with the family is the key to coming up with the best possible decisions. To summarize what I've said so far, it all boils down to those four principles of medical ethics. What's important to the family and what's important to the patient may not be the same as what's important to you. The patient and their family have the right to be wrong. Disagreeing with you doesn't necessarily mean that they're wrong. Not everything has to be medicated, biopsied, scoped, probed, tested, intubated, radiated, MRI'd, or operated. Try to get a hold of the house of God. It's as true today as it was when it first came out. DNR in the perioperative period. The next 10 slides are something I wrote as part of a proposal for a hospital policy decision in the RWJ Barnabas healthcare system. They've accepted this, and it's going to be formalized for perioperative care at all RWJ Barnabas medical centers. A DNR order is not automatically suspended when a patient requires a procedure. Every major medical organization agrees to that. Discussing the perioperative goals with the patient and their family is called required reconsideration. Remember, the surgeon's goal is cure, amelioration, maintenance, or palliation. The patient's goal is the same, but the patient's main concern is that if something goes wrong during the operation, they don't want to wake up or not wake up in a vastly diminished quality of life where now they're tethered to a ventilator for the rest of their lives or stroked out or otherwise turned into a persistent vegetative state. Patients don't want to be that post-op. The anesthesiologist's goal is to try to reconcile the surgeon's and the patient's goals. And the way to do that is to discuss with the family, discuss what they think resuscitation means. What does the patient think resuscitation means? We think resuscitation means helping straighten out a complication that arises. For instance, you hit a bleeder, blood pressure goes down, the anesthesiologist will give some fluid or blood products, everything straightens out. Patient may need to be intubated as a matter of course during a procedure. Maybe the patient's DNR says do not intubate, but if we intubate you for an exploratory lap or to take out your appendix and we can extubate you at the end of the case, then why not allow intubation? So these are some of the things to discuss with the patient and their family, because our goal is to get the patient through with their goal on this procedure that they need to have. Maybe someone whose DNR fell and broke a hip, now they need surgery, now they'll need anesthesia. The planned procedure may or may not be related to the underlying cause of their chronic illness. And so we want to do what's best for the patient and what the patient most wants. Provide the care that the patient would prefer. Here are the references to those last few slides, because that's how I proposed it to the RWJ Barnabas system. A few things about DNR in the news. Here's a patient. This lady's mother was a patient who was known to have stomach cancer. She underwent multiple EGDs. On one of them, their DNR order was ignored. Patient developed a complication in the recovery room. They ended up having to be intubated in the ICU, and in the remaining few weeks of that patient's life, it was just a horrible quality of life that they had, and because they ignored the DNR order. This person showed up in the ER with "do not resuscitate" tattooed on their chest. They came in with acute alcohol poisoning. They were unstable. The ER docs weren't sure what to do. They ended up honoring this DNR request, which was later found to be on the patient's older chart. This 80-year-old gentleman was having breakfast in the nursing home. He was DNR. He started choking on a piece of food. Nobody thought to do a Heimlich maneuver. They called 911. Paramedics were dispatched. Then somebody saw that he was DNR. They called back 911 and they canceled the paramedics, and the patient died. If someone had done a Heimlich maneuver, very likely he would have been saved and would have been right back to his previous state, but no one thought to do that. Healthcare for minors, let's switch a little bit to pediatrics. I'm going to skip over some of the things which may not be the most important for the next few minutes we have left. What I do want to go into is that minors do have the right to certain treatment and care, even without their parental consent. That includes contraception, pregnancy care, sexually transmitted diseases, HIV, treatment for alcohol or drug abuse, outpatient mental health treatment, and for sexual assault. It's felt that allowing kids to have that treatment without parental consent, kids may be afraid to ask their parents. Parents may not take well to finding these things out. And it would benefit patients and society as a whole if these kids could get this kind of help, even without parental consent. Otherwise, the kids wouldn't go for treatment or for care. Confidentiality is very, very important for us when speaking to the patient. When speaking to their parents, the parents need to realize that we are going to talk to patients, their underage, their children, in confidentiality, and parents may be asked to leave the room while we speak to the patient. There should be private conversation time between the healthcare provider and that adolescent patient. There's also a concept of the emancipated minor. A minor can become emancipated if they are pregnant, if they join the armed forces, which you can do when you're only 17, when they give birth, or even in the case of a male minor, if he is a parent who is acting responsibly in helping take care and raise the child, then he too gets emancipated status. Or if you get married under age 18, which in some states is still allowed. Here's a nice summary of the laws in New Jersey of the emancipated minor, as well as those conditions in which a minor can get treatment without their parents' permission. And here's a nice summary of state and federal law regarding patient confidentiality for minors. Pregnancy testing prior to anesthesia. There is no policy here in the hospital, even though we do pregnancy tests in the PEDS pre-op area as well as in the emergency department. I have proposed the next few slides to the RWJ Barnabas System's legal department. They agree with what I have to say and what my recommendations are. They asked me to hold off with presenting most of this, but I will tell you what the basic problems are. Many governing bodies of different specialties say that you have to have consent for doing a pregnancy test. We're not doing that here. Number two, what are you going to do with a positive test result on a minor? You're going to cancel a case and send the patient home. Is there a legal or ethical obligation to have someone speak to the patient without the presence of their parents? Should the social worker from PEDS or from OB come speak to the patient, start talking to them about what their options are, give them a referral to this department for follow-up care? Also, someone's got to ask the patient, especially if she's under 16, how did you get pregnant? Was there force, coercion, an assault, an inappropriate older family member or teacher or coach or something like that? How did you get pregnant? What were the circumstances? And is this something that we then, as medical professionals, need to report to the state? So all that is being clarified, and so I'll hold off with mentioning my recommendations. Also, when we do pregnancy tests, it's my understanding that the urine pregnancy test is most accurate for a patient who has missed her expected onset of a menstrual cycle. whereas we do pregnancy tests on anybody under 18. And I wonder how accurate those are if it doesn't meet this highlighted criteria. The rate of positive pregnancy tests in kids is relatively low, but still every few weeks we get a positive test result. And we just cancel the case, send the patient home, and I always wondered if that's the right thing to do. And finally, the legal department's going to find out for me. Because we are mandatory reporters of potential child abuse. And a few things now about obstetrics. If I'm wrong about any of these, please tell me. Can a woman in labor refuse a C-section? It is my understanding, even in fetal distress, the answer is yes. If you feel strongly that the patient has lost capacity or did not have capacity, then you can declare that person to be without capacity and go ahead with a C-section in emergency. However, you may find yourself having to take that patient to the operating room, literally kicking and screaming. It's a very ugly scenario. You may have to answer a lot of questions afterward from the patient, their family, and other authorities. Can a woman refuse prenatal care or interventions on behalf of the fetus? Again, the answer is yes. It's her baby, not yours, assuming she has capacity. Can premature or critically ill babies' care be withheld or withdrawn? The answer is yes, not unlike an elderly person. If you feel that the treatment and care is no longer appropriate, life is not being prolonged, but rather death is being postponed, the situation is incompatible with life, and treatment is judged to be harmful and of no benefit. A very important landmark case in the world of pregnancy and catastrophic illness and brain death is the case of Marlise Munoz. This happened in Texas a few years ago. Here's a lady who was 14 weeks pregnant. She collapsed at home from a brain hemorrhage. By the time the husband found her, she had already been laying on the floor and anoxic for a considerable period of time. She was taken to the hospital, declared brain dead. There was possible damage to the fetus from that prolonged period of anoxia. The husband wanted to disconnect her from life support because she was brain dead and the fetus was severely malformed. Texas law did not allow him to do that. It was appealed through numerous courts. Finally, a judge said that Texas law is wrong because Texas law says that a pregnant person, you cannot withdraw or life-sustaining treatment from someone who is pregnant, but Texas law also recognizes brain death as legitimate death. Therefore, if a patient is brain dead, they are not really a patient anymore. They are a deceased body. Therefore, the judge ruled in favor of the husband. There's also the case of Robin Benson, which was a much easier case in that the fetus she was carrying at the time of her catastrophic brain death was normal and near term, and so she was kept going on a ventilator and feeding devices until the baby could be delivered by C-section, at which time her ventilator was disconnected. The world of reproductive medicine has many ethical challenges and questions that have been raised. If you look at their website, there are many position statements and ethics documents. I'll leave it to you to read through these and just to get an idea of some of the many ethics issues that arise in reproductive medicine. There are new technologies coming out, such as the artificial amnion and placental technologies, where you could take a severely premature baby and perhaps even someday a zygote and transfer them to this artificial environment in the laboratory for that premature or very early pregnancy to be raised in that device. And then when the fetus is mature, call the parents to come pick them up. There's this idea of complete ectogenesis, when gestation can be done completely from conception to birth in an external environment. There's a whole world of these ethical issues that are going to rise from this. changing the genetics of a zygote to remove undesirable genes or change them to more desirable genes. A couple of cases that were landmark, both here in New Jersey, both happened at the time of my being a medical student and a resident. The baby M case, these are both cases involving surrogate parenthood and the problems that arose because there were no laws to regulate the world of surrogate parenthood, especially when the hired surrogate mother changes her mind about giving the baby back to the parents who hired her. The baby M case was a case where the surrogate mother's ovum was used and the sperm of the father of the couple who hired her was used. She changed her mind after she surrendered the baby when it was born, surrendering it to the parents who hired her. She then kidnapped the baby. It was a huge legal mess. Eventually, the parents were awarded custody of the infant. Actually, the father of the baby was awarded custody. The woman who physically gave birth to the child was allowed visitation rights. And when the child turned 18, with the child's permission, who is now an adult, the parents legally adopted her. In Robinson versus Hollingworth, this was a gay couple who hired the sister of one of them to carry a baby on their behalf because they wanted to have a child. They used a donor ovum from someone else and the sperm of Robinson, who was not the brother of the woman that they hired. And this woman gave birth to twins. She refused to give them up. The court battles were incredibly ugly. Eventually, the judge decided to award the baby to the gay couple, which in the 1980s was a very eyebrow-raising decision. And the judge felt that this was truly in the best interest of the child. Since those days, the New Jersey legislature has passed the Gestational Carrier Agreement Act, which protects both sides in such gestational surrogacy agreements. Although keep in mind that this law only covers cases where the surrogate does not have any genetic involvement with the baby. The ovum and sperm both came from sources, well, the ovum came from somewhere other than the surrogate mother that was hired. If you are going to use a surrogate mother and use her ovum and the the father of the couple's semen, then all bets are off and these laws do not apply. And if you hire someone who later reneges on that contract, you have no legal recourse. Here's some details about the baby M case, some details about Robinson and Hollingsworth. Please read those when you get a chance. Here's a New Jersey couple that tried to use a surrogate mother in Mexico. Mexico and Ukraine were always favorite places to find surrogate mothers. There were agencies that would arrange that for you. The Mexican government gave them a very, very hard time about bringing that baby back to the United States. Eventually, they reneged and allowed them to do that. An important point, which since we're nearing the end, pelvic exams and other procedures performed on anesthetized patients by students and residents, especially if it's of no benefit whatsoever to the patient, you need the patient's consent for that. You cannot have a patient, as I've seen over the years, in stirrups, under anesthesia, and now you've got a bunch of medical students and residents all taking turns doing a pelvic exam. You can't do that unless you get consent from the patient ahead of time. And I would extend that even to the anesthesiology department, as I told them the other day, that if you're going to let a student or resident intubate or put in a central line and so on, you have to get the patient's consent. There are several ways of going about that, either supplemental consent, added to the surgical consent. This should be part of the learning process and orientation to all students and residents that here's the way it has to be. We got to get the patient's consent if you want to participate or have anything or examine the patient while they're under anesthesia. A few words about brain death. excuse me, there are 3 criteria. Patient's got to be permanently unconscious, no brainstem reflexes, no neurologically driven respiration. These 3 things, the American Academy of Neurology did not ever specify what tests should be done to establish brain death. That didn't happen until 2020, when a panel of experts came together and came up with these clinical criteria of brain death, which can be done at the bedside. That didn't happen until the year 2020. There are all kinds of perfusion studies that radiology can do. However, many of them have false positives, false negatives. If a patient has an infratentorial lesion, they can still have blood flow to the cerebrum, but be in a so-called severe locked-in state, which looks exactly like brain death. And you have to wonder if sometimes patients have been declared brain dead when in fact they have a severe locked-in condition. And that's discussed in the next few slides. I'm not sure if we'll have time to get to them, but that's something you'll see. If please read these slides when we get a chance. A couple of important landmark cases, which are the basis for everything I've spoken about so far. Karen Ann Quinlan, Nancy Cruzan, I mentioned Marlise Munoz, Terry Schiavo, Jahi McMath, which happened here at RWJ, Jeffrey Strachan, which happened a few miles away at JFK and Edison. Here's some thoughts about the Jahi McMath case. Was she in fact not truly brain dead, but in a severe locked-in state, closely resembling brain death? Her final autopsy did not show a lot of necrosis of the brain. Her brain was still in relatively good shape supratentorially at her autopsy. Here's an article I asked you to read on your own. It is mind-boggling to see how the brain reacts when you decide not to continue mechanical ventilation on a patient and decide to let them die. In the final moments, the history of race and medical ethics. This is in the mid-1850s. The father of modern day anesthesiology, experimentally giving anesthesia for the first time to a African-American person who in Georgia in the mid-1950s was no doubt a slave. I'm sure that slave had no say in this process of being anesthetized, being the first person to ever get anesthesia with open drop ether. Whether he even needed the surgery or not, God only knows. This was a very prominent physician back in the day, also in the South in the mid-1800s. He fancied himself on an expert on African Americans. He couldn't understand why slaves would want to run away. He thought slavery was so enjoyable, this particular doctor. He also couldn't understand why slaves would sometimes disobey their taskmasters. He gave that a medical diagnosis of a name. When I was an OB resident, I was led to believe that this was a picture I should revere. Turns out that Dr. Sims experimented on slaves, in particular, about 5 or 6 of them who were only known by their first names. He operated on them with vaginal surgery without the benefit of anesthesia. He felt that African Americans did not feel pain nearly as much as white people did. And so he felt it was not a big deal to have these 2 thugs hold this lady down while he experimented and performed surgery on her. His invention of the speculum and of one of the first forceps was done by experimenting on Black slaves who were giving birth. Take a close look at this picture, the frightened look on these 2 ladies' faces. I'm sure you've all heard of the Tuskegee experiment. I'll leave it to you to read up on that if you don't, but it was an absolute horror. There is a long, very painful history in the United States and in other countries of taking advantage of people who have are extremely vulnerable, who have no say in their own lives, in their own care, and using them for medical experimentation. Henrietta Lacks is another such story. Please read about that. Here's the anatomy department from the University of Vienna in the 1930s and 40s. They would visit concentration camps, pick out prisoners that they wanted to have killed so they could use them for anatomic drawings. They were all loyal members of the Nazi Party. They would show up for work in Nazi SS uniforms. They all signed their names to their anatomic drawings with either a swastika or the SS symbol. Clemente's anatomy, which I used as a medical student, he edited that. He used the same drawings from the Pernkopf atlas, but he edited out the swastika from their names. Take a good look at this patient's picture and come to your own conclusions where they got him. I visited Sachsenhausen concentration camp. I was in the room where this was found. Well, when I was there, were pictures of some of these atrocities on the walls of what happened in that very room. I saw this very table. Nazis would amputate the limbs of inmates in the concentration camp, again, without the benefit of anesthesia. It was a grand experiment to try to reattach those limbs because the goal was to cut limbs off of concentration camp inmates and attach them to German soldiers who lost their limbs in battle. The great Dr. Raoul Artel, who gave this very lecture to this department about 7 years ago, he himself was born in a concentration camp. He became a major voice for ethics and medical research. And finally, let me summarize medical ethics with 3 quotes, one from St. Ignatius Loyola. Everything we do should be for the greater glory of God or whatever higher power you believe in and for the salvation of humanity. This morning, many of you will go to the operating room, the pre-op area, meet a patient for the very first time. In a matter of minutes, you will establish a heart-to-heart connection with them, and they will entrust you with their lives and their safety. You have made the world a better place with that interaction with that patient. Here is the story of Jerzy Bielski, his autobiography. He was a Polish resistance fighter against the Nazis. They captured him. They sentenced him to death by starvation. A priest by the name of Maximilian Kolbe offered his life in place of his. So his life was spared. He was so moved by this that he tried to rescue as many inmates in Auschwitz as he could and help them escape. So the book is entitled, "Who Saves a Single Life? It is as though they saved the entire world." And the great quote from the Talmudic scholar Hillel, who 1,000 years ago said, "I have to look out for myself, but if I am only for myself, if I'm only looking out for myself, then what kind of person am I?" So in summary, let me say, let medical ethics bring out the best in you. And thank you very much.
All right. Thank you, Dr. Stein. Thank you so much. Are there any questions?
I have a question, Dr. Stein. Thank you so much for that very comprehensive talk and just so interesting. You mentioned in your first slide, virtues of compassion and self-sacrifice was something that you wrote down. And I'm just curious what you think, in recent years, there have been, there was like a New York Times article calling the moral crisis of America's doctors. I think just the other week, there was something in Wall Street Journal also looking at, is a career or a calling? There was an article about in medicine, and a lot of this discussion centered on now that many autonomy versus bureaucracy, with many doctors now being employed and exchanges, a lot of medicine sometimes being seen as like exchange of services. How do you think this impacts those things, those very things you were talking about, or maybe it doesn't, virtues, or poses a challenge or a risk to those things?
I believe it's up to us who have been in practice for many years and who understand these pitfalls and problems, especially with medical care and health insurance being taken over by non-physicians and where their motive is strictly money-making. It is important for us to present good examples to the upcoming generation of students and residents on what's right in medicine and how to be a good doctor, the importance of those 4 principles. The best way to do it is not by mandating things or passing laws requiring things or requirements, but rather by setting a good example. It's up to those of us who are of a certain age and a certain level of experience to set a good example, because the best way to transmit good values is by setting a good example.
All right. I think we could discuss this all morning, but unfortunately I have a mandate to end at exactly 9 o'clock. So we're going to have to wrap it up, Dr. Stein. Thank you so much for coming this morning.
Thank you. I must say, having attended the lecture of Dr. Raul Artel about 7 years ago here, it is a great honor and privilege for me to be giving the lecture on that same topic as he.
That's great. Thank you so much.
Dr. Stein. Thank you.
Thank you, everyone.
All right, so we're going to have to wrap it up here. Thank you, everyone, for your attention this morning. I hope you all have a safe and successful day. Thank you.